So we'll give a few minutes for everyone to kind of get logged in right now. Let's see the participants kind of joining in. All right, good evening, everybody. As you guys are joining, make sure to try to mute your mics as you're coming in. All the standard Zoom etiquette that I'm sure everyone is very familiar with at this point of time. All right, I'm going to go ahead and get started. We'll have some other folks that are trickling in right now. So good evening. I'm Raja Narayan. I'm going to be starting us off. Thank you for joining us this evening for the high yield topics portion on the ABSITE for 2022 review for your upcoming exam in 2023. This is the first of two sessions that we're going to be holding for you guys. So this session has a series of topics that we'll cover that are going to be different from the topics that are covered for the part 2 session that's going to be happening in January. These are information if you guys want to tweet or whatever for that. And I do want to give a quick plug in to the SSAT. So the majority of people that are joining are probably residents here. So you can see that in order to join, you would be a candidate member. And so it's fairly cheap to be a member of this society, where there are great opportunities for networking with other trainees around the country, as well as faculty that are involved in a lot of different academic institutions around as well. And it's a great opportunity to get experience working in organizations like this with folks from other institutions, and certainly is something that helps, especially as you're promoting yourself up the academic ladder and showing that you've had the opportunity to work with societies at different levels. So I heavily encourage you to get involved. Part of the perks that are associated with being a member of the SSAT involves getting free access to our Journal of GI Surgery, and also getting a deep discount when registering for Digestive Disease Week, which includes several societies in addition to this total umbrella of the DDW meeting. There are also a bunch of awards, grants, scholarships, and traveling fellowships that you become eligible for once you're a member of the SSAT, as well as the leadership opportunities that I mentioned just now. And then we have a whole section on the website at the SSAT that is a residence corner that's got interviews with mentors from around the country, ABSITE quizzes to also help you prep, and then libraries of videos of operations as well for reference, as well as past webinars, including this webinar that will be posted up there after we finish recording. So here's our lineup for this evening. So we're going to start off with Dr. Rachel Kim, who's going to be giving an overview of HPB and transplant, followed by Dr. Wilson Alubia, who's going to be giving an overview of endocrine and GI hormones. And then we're going to end on colorectal with Dr. Connie Shao. So I'm glad that we have members from different institutions from all over the country representing today. So this is going to be a great treat for everyone, and it's going to be a great review for you. And as I mentioned, we'll have a copy of this webinar that's available for you to review on the website. It'll also be on YouTube, or if you're more of an audio person, it'll be available at the Apple and Spotify podcast website, all for free for you to reference if you'd like to listen to it again later or give it to a friend in your program. And then just a quick couple of thanks to the folks that are going to be presenting today. Thank you, as well as the SSAT, as well as the resident and fellow education committee that helps organize and fund this opportunity for you guys to have folks together to learn about the different topics we're going to talk about today. Thank you to Dr. Maria Altieri, who's our committee chair that makes this possible. And I have to give a thanks to Dr. Z Van Fong, who's our moderator emeritus from the last time they got me involved in this to be able to present as well. And thank you to Beverly Hendry, who is our organizing workforce that's helped us put things together today and has been helping with the polls that you'll be seeing as part of the questions as we go through the subjects. So I think that's all I've got. I'm going to stop sharing and I'm going to turn it over to Dr. Rachel Kim, who's going to lead us off with HPV.
Thanks for the introduction, Raja. Let me just share my screen. All right. All right. So, like he said, my name is Rachel Kim. I'm a current general surgery resident at Indiana University, and I'm happy to give this talk and wish everyone luck on the ABSITE this year. HPB and transplant is a lot of content, so I'll just be focusing on mainly the high yield topics and kind of the highlights of each topic. So obviously, there's a lot more in all of the regions, but this hopefully should be a good overview of sort of all the different areas in this very diverse topic. So we'll start with liver and just going straight with anatomy. So at this point, a lot of, I think the senior residents obviously will know this anatomy very well, but please make sure, but it's definitely highly testable to know the 8 numbered segments of the liver, but also the orientation of the portal triad. So the medial duct is the medial structure, I should say, is the hepatic artery proper, not the common hepatic. Remember that the common hepatic sort of transitions into the hepatic artery proper after branching off into the GDA, or the gastroduodenal artery. The lateral structure is the common bile duct, and the final posterior structure is the portal vein. I kind of remember as the portal vein as being sort of the fattest and the widest of the 3, and so it kind of provides a bed for the bile duct and the artery to sit on, and then the artery is the medial, and then the bile duct is the most lateral. This is sort of just kind of basic things. Remember that the division between the right and the left side of the liver is not the falciform ligament. It is Cantley's line. It is the sort of imaginary line that connects the gallbladder fossa to the IVC. And then I think the most relevant part in terms of knowing the segments is knowing which segments will be resected for the various different types of segmentectomies. So the right liver is composed of segments 5, 6, 7, and 8. It goes in a sort of clockwise fashion, starting from sort of the anterior lower side. And then the anterior segments include 5 and 8, with the segment 5 being below segment 8. And like I said, going clockwise from there. The left segments include segments 2, 3, and 4, with 4 being the medial segments and 4 being also sectioned into 4A and 4B. And the most lateral segments being sections 2 and 3. The caudate segment, or segment 1, is sort of in the center of all this under the, if you kind of flip the liver like a loaf of bread to the underside, you'll get to see that in the center segment here. So when we talk about a right hepatectomy, we're talking about segments 5, 6, 7, and 8. When we talk about a left hepatectomy, we're talking about segments 2, 3, and 4. A caudate resection is something separate. When we are talking about just a right anterior segmentectomy, that's 5 and 8. Left lateral, for example, is only 2 and 3. When we're extending either side, so we're usually talking about extending it to either the medial segment that's most adjacent. So for an extended right, that includes all the segments of the right section, and then also the left medial segments, which includes segments 4A and 4B. When we talk about an extended left, we are extending the left segment, or the left side, to the right anterior segments. So it's all the segments of the left side, which is 2, 3, and 4, including 4A and 4B, and then as well as the right anterior segments, which is 5 and 8. So in terms of vasculature, so we all know that the liver is composed of 2 different blood supplies. The portal system composes 2/3 of the blood supply to the liver, and the portal vein itself is a confluence of the SMV, or the superior mesenteric vein, and the splenic, while the arterial system is actually only 1/3 of the blood supply. So this is the blood flow coming from the hepatic arteries and its branches. But even though it's only composing 1/3 of the blood supply, it's still a very important blood supply for the liver, because it does supply most hepatic tumors. And this is how I remember that when we talk about hepatic artery infusion pumps, or TACE, and other sort of interventional treatments or interventional non-surgical treatments for hepatic malignancies, we are talking about systemic therapy through the arterial system, not the portal system, because that is what supplies these tumors. One thing that the ABSITE likes to test on is aberrant hepatic anatomy, particularly aberrant vasculature. That comes up a lot. The most common aberrant right hepatic anatomy is a replaced right artery coming off of the SMA. It can be replaced or it can be an accessory. If it's an accessory, it means that you still have the most common, the typical variant in addition to an additional artery, but most commonly it's a replaced where you don't have the common variant and you only have the artery coming off of the SMA. A replaced right hepatic artery coming off of the SMA, it travels posterior to the pancreas and the common bile duct. And so that's something you should be aware of, especially if you're doing any sort of dissection in that area. And this is why it's so important to get at least a multiple phase CT scan to evaluate for the arterial anatomy for the hepatic arterial system before you do any sort of surgery in that area, including even cholecystectomy. The most common, replaced left hepatic artery. It comes off of the left gastric, and this travels in the gastrohepatic ligament. So that's also something to be aware of as well. The replaced right anatomy is slightly sometimes less common than the replaced left anatomy, but these are the two most common, and there are other variants that you can see. But I think that for the ABSITE purposes, this is the most commonly tested. And then in terms of drainage, the drainage comes from the hepatic veins. They are from the right, middle, and left veins. In about 80% of patients, the middle hepatic confluences with the left hepatic before reaching the IVC. And then in the other 20%, the middle hepatic drains directly into the IVC. So going into sort of portal hypertension, something we've learned since med school, it's defined by the hepatic vein pressure gradient. And technically the definition of portal hypertension is any gradient pressure or a gradient pressure greater than 6 millimeters of mercury, Is the hepatic vein pressure gradient is the wedge pressure minus the free hepatic vein pressure. So it's essentially a gradient between the portal system and the IVC system or the systemic system. Like I said, the threshold is 6 millimeters of mercury in terms of definition, but between 5 and 9 millimeters, you usually get a subclinical disease, and you usually don't actually start seeing sequela of portal hypertension until you get into the double digits, so greater than 10 to 12 or so. It's typically classified into pre-sinusoidal, pre-portal, sinusoidal, and post-sinusoidal. The most common being sinusoidal, which encompasses any cirrhotic state. So that includes all the hepatitis viruses, alcoholic cirrhosis, fatty liver disease, things like that. Post-sinusoidal, where you have your disease etiology sort of after the actual disease liver parenchyma. And then pre-sinusoidal, we always talk about this as an example, it's schistosomiasis. I've actually never seen that very much before, but it's a very classic sort of pre-sinusoidal example. So I think in terms of the surgical world, where we come into play with portal hypertension the most is with varices, and we see a lot of variceal bleeding, and we get called and consulted a lot for that. Obviously, you develop varices anytime the splanchnic or the portal system meets the systemic drainage. And so the most common area is obviously the distal esophagus and proximal stomach. That's where we get our esophageal varices that we're always getting called about. You can get umbilical varices, also known as caput medusae. In the rectum, where the inferior mesenteric vein and the pudendal systems kind of meet, and as well as retroperitoneal varices as well. And then in terms of management, so the primary or the first line management for these patients is actually not us, it's medicine. Beta blockers is one of the first line prophylactic agents. In the acute settings, we can also consider giving vasopressin and octreotide to help improve the bleeding or helps stave off bleeding. But if they are actually having variceal bleeding, obviously, the first line treatment for the acute setting is to do an endoscopic, to intervene endoscopically if needed through interventional radiology as well. But if they continue to have repeat acute variceal bleeding, then you might have to go a step further and treat the underlying portal hypertension and the underlying cause of the varices before they can actually improve from the variceal standpoint. So this includes shunts, and the most common shunt that we will see obviously is the TIPS procedure. In terms of general portal hypertension management, there's also more selective shunts like the splenorenal or Warren shunt. However, because these are more selective shunts, they won't necessarily relieve all of the sequelae of portal hypertension. So for example, the splenorenal shunt will not relieve ascites. And then there are non-systemic selective shunts, non-selective shunts like the portal cable shunts, less common because they have a lot of side effects, a lot of detrimental sequelae to the patient, but they are there if you, while you're trying to wait for transplant, for example, if need be. So going to our first kind of poll question, we have a 58-year-old male with cirrhosis who previously had a TIPS, but now has but the TIPS is now stenosed and no longer functional. He develops hypotension, and melena, and EGD demonstrates esophageal variceal bleeding, which cannot be controlled endoscopically. IR is unable to embolize because of multiple points of bleeding. So what is the best method to prevent recurrent variceal bleeding? And then this will fall under question 1 for the polls.
So you guys should see a little pop-up that's now present that you can vote, so we can kind of gauge the audience. We're not going to know who votes for what. This is just kind of for your own thing to commit to something, and then we can talk about the answer here.
And then Raja, I'm not able to see like the data for that. So whenever you feel like we kind of get quorum.
So I am not seeing responses just yet. Beverly, can you see if the function to vote is present for people? Are you guys able to see the letters to vote for? Are you guys able to see the options to vote for?
I think we have to choose the answers for all 8 questions before we can submit them.
Correct.
Oh,
all of them. Okay, I see.
interesting. Okay.
Okay. Well, then why don't we just go ahead and kind of, so you've locked in your vote mentally then.
All right. So now that you've had time to consider the question, should we just kind of give them a pause, Raja? Yeah, okay. So the option choices here, the correct answer is actually, let me see, liver transplant. So this is where understanding the question stem and understanding what the question is specifically asking you is the key here. So octreotide drips and beta blockers have a role in prevention as well as in trying to stave off acute bleeding, but it's not going to prevent recurrent bleeding. Balloon tamponade is also a sort of temporary way to try to tamponade the bleeding while you're trying to get the patient more stable and to your planned intervention. Partial esophagectomy, it can remove varices, and it was sort of an old school method of treating varices, but we don't really see that anymore. So the best method to prevent recurrent bleeding here is to take care of the underlying portal hypertension. And in this case, since he's already failed a shunt, since he's already failed a TIPS, unfortunately his only option now is a liver transplant. Okay, so moving on to hepatic lesions, we're going to start off with abscesses. So we have all probably seen at least one pyogenic abscess. They're the most common liver abscess, with the most common etiology being actually polymicrobial, so multiple bacteria, usually GNRs. If we're talking single agents, the most common is E. coli, the second being Klebsiella pneumoniae, particularly in the Asian population, and then the third most common being Strep angino. This is just a random question that I remember from a prior ABSITE that I got wrong at the time. So if this helps you get 1 point, I hope it does. But the most common cryptogenic organism, which is when you don't identify an obvious organism, is actually Klebsiella. The treatment is antibiotics plus or minus. You can consider drainage for large abscesses, but anything smaller than 2 centimeters, usually antibiotics is sufficient. Obviously, you need to monitor their clinical symptoms, signs and symptoms to continue to monitor that. We have parasitic or echinococcal cysts as well. These have the classic water lily sign, that double walled floating undulated membrane in the cyst. These you don't want to aspirate or drain or as a simple procedure at least, because then you risk spillage and anaphylactic reactions. So the treatment for this, usually most cysts respond very well to medical treatment like albendazole or mebendazole. But more complex cysts, you can consider surgical resection, or you can do a pair procedure where you actually inject and re-aspirate and aspirate in a sort of more complex interventional procedure. And then the third sort of big type of liver cyst is amoebic cysts, most common being entamoeba histolytica. These are really hard to differentiate on imaging from pyogenic cysts, although more commonly the amoebic cysts are single loculated or uniloculated, while you can get multiloculated pyogenic cysts. But I think the key here for the ABSITE will be the history. So they typically tell you some travel history to like a region like South or Central America or Asia or Africa, and that should be your hint that they might be pointing you towards an amoebic cyst. And these you do not need you typically do not need to do an intervention. They react very well, or they are managed very easily with metronidazole or flagyl. And then if there are fungal cysts, you usually only see them in immunocompromised patients who are susceptible to superinfections. So benign liver lesions. So I'm just going to go over sort of some general facts really quick, but I think most people are most interested in how do you differentiate between them on the image, cross-sectional imaging. I think those are very commonly tested. So hemangiomas are the most common benign liver lesions. They usually are in the mid life, third to fifth decade. Something for the ABSITE is to be aware of the Kasabach-Merritt syndrome. That's a consumptive coagulopathy that you might see in kids. And then these are just some buzzwords that you might see, that peripheral to central enhancement or centrifugal enhancement, which will show you images of in a little bit. Excuse me. The second most common is focal nodular hyperplasias. These are completely benign. Typically, they have that classic central scar. So the only real reason that you really need to resect them is if they're symptomatic. Something else to know is that they do have Kupffer cells. So if you ever see on the ABSITE where if they do a sulfur colloid scan, then they should take up the sulfur colloid. And then the third more commonly tested, I should say, benign liver lesion is hepatic adenoma. This is the one that's associated with the birth control use. However, just be aware that that's not its only association. It's also associated with lots of glycogen storage diseases and other sort of genetic syndromes. These do have a malignant potential, and then the other risk that they have is for rupture and bleed. So it's a little counterintuitive. Hemangiomas are technically low risk for ruptures, even though you think of them as a very vascular lesion, but it's the adenomas that have the risk for rupture and hemorrhage. So there's a lot of indications for resection. Large lesions, regardless of whether they are associated with birth control use, that is an indication for resection. So anything over grade 5 centimeters, it is reasonable to surgically resect that. Obviously, any symptomatic lesions, and if someone's unable to stop being on their hormone therapy, it would be another reason to consider resection as well. And then in terms of malignant liver lesions, remember that the most common malignant liver lesion is not a primary liver tumor, but actually a metastatic tumor. But in terms of primary liver tumors, there's hepatocellular carcinoma, or HCC. That's the most common primary hepatic malignancy. There are different variants with the fibrolamellar variant, which you can see in the younger populations having the best prognosis. Anything that kind of puts the liver parenchyma at a constant or chronic inflammatory state can be a risk factor, including cirrhosis, alcohol smoking, diabetes, etc. And then cholangiocarcinoma is the second most common primary hepatic, but within cholangiocarcinomas themselves, intrahepatic cholangiocarcinoma is actually the least common cholangiocarcinoma. So within the liver, cholangiocarcinoma is the second most common, but within cholangiocarcinomas, the Klatskin tumors, which is near the right and left hepatic duct confluence, is the most common, then distal cholangiocarcinomas, and then intrahepatic cholangiocarcinomas. So this is sort of where the money is, I think, that everyone kind of has questions about every year. So this is, I pulled these images from MRI slides. So there's a lot of extra phases that you probably won't be tested on as much. But I think the key here is the arterial, portal, venous, and delayed phases. The hemangioma, so you're going to have that peripheral to central enhancement, and it's going to be nodular. So you might even see the term or the descriptor peripheral nodular enhancement. And the other key is that on the delayed phase, there's a persistent enhancement of these lesions. So they should continue to appear bright on your delayed phase. A focal nodular hyperplasia, that's that central scar. It's very distinct. And in most, in the arterial phase, that central scar is hypoattenuating or hypoenhancing. But once you get to the delayed phase, sometimes that scar may enhance. It's a rapid arterial enhancement, but then it becomes more hypo to iso enhancing on the delayed and portal venous phases. And then hepatic adenoma, that has a transient homogeneous rather than the nodular like the hemangioma, but a homogeneous arterial enhancement. It also becomes more iso-intense on the portal venous or delayed phases. So between the benign lesions, I think the nodular enhancement, the central scar, and the homogeneous enhancement is sort of the defining features on the arterial phase, and then knowing what stays enhancing on the delayed phase is actually useful as well. Going to the malignant lesions, so hepatocellular carcinomas or HCCs have an intense arterial enhancement. And again, this goes back to when I mentioned that malignant tumors tend to be supplied by the arterial system here. And so that's reflected in its imaging. But one way you can distinguish it between an adenoma and an hemangioma is that on a delayed phase, it should become hypoattenuating. It should become much more hypoenhancing to the rest of the liver parenchyma. And then for metastases and cholangiocarcinomas, so this is typically hypoenhancing on all phases. You might get some slight peripheral enhancement if you wait long enough in the delayed and portal venous phases. And then for cholangiocarcinomas, because they're arising from the actual bile ducts, you might see some capsular retractions and some duct dilation as well. So another question, a 33-year-old female has a 2-centimeter mass on the right side of the liver, found incidentally. She's otherwise healthy. She's been taking birth control since age 17. She denies any abdominal pain. And on triple phase CT, this lesion will most likely display which of the following. So we know that she's on the younger side, has a small lesion, and this mass was found incidentally. So I'll give you guys a little bit to think about that.
We have the chat function enabled, so why don't you just throw your answers in there, guys, so we can kind of see, and we'll spend more time talking about this if there's a distribution of answers, but if there's a lot coalescing around the same thing, then we can kind of blast through this. I'll give you guys like a few seconds to put in your answers there.
Okay, so it kind of looks like everyone's between A and B, and I kind of expected that. So the answer is actually C, and this is from SCORE. So this is kind of a trick question. So they give you a lot of buzzwords like the OCP usage that is associated with hepatic adenoma, which is actually not an option choice here. But remember that the most common benign liver lesion is hemangiomas, regardless of demographic, although she is female and hemangiomas are more common in the female population. And so the answer choice that's more associated with hemangiomas is that peripheral nodular enhancement. Arterial enhancement and washout on the delayed phase, that's associated with malignancies. Remember that that's malignant tumors have that washout on the delayed phase, so HCC. The central scar is associated with focal nodular hyperplasia, and then the peripheral enhancing lesion in the arterial phase is kind of a non-distinct term, but it might be associated with other malignant tumors. But remember that the most common benign lesion is a hemangioma, and the imaging characteristic that's associated with that is peripheral nodular enhancement. Okay, so I had another question here, but I think in the interest of time, we'll continue on. But but the slides will be available and you'll be able to answer those questions on your own. And these are also all from the surgical core score, so you might come across these questions on your own studying. Some other things to remember for liver, so future liver remnant. So remember that for healthy patients, you only need about 25% of your liver. If you have any sort of liver disease or cirrhosis, you'll need more. You can consider a selective embolization of the portal vein in order to help you increase your future liver remnant. Remember that you're embolizing your ipsilateral side, so the side with the lesion, so that you get contralateral hypertrophy. And then in terms of using transplantation to treat some of these malignancies, the main criteria that you'll be tested on for the ABSITE is the Milan criteria. So that's having one lesion less than 5 centimeters or 3 lesions, fewer than 3 lesions, I should say, with a total diameter of all less than 3 centimeters in diameter. So you can have 3 or fewer less than 3 centimeters. And obviously you shouldn't have any vascular invasion or extrahepatic spread. And this actually includes any nodal disease. And then the UCSF criteria is not on score yet. So I don't think I don't think we're expected to be responsible for it just yet. So just really quickly, we have a 59-year-old male with Hep C and cirrhosis, has a 3-centimeter nodule on screening ultrasound, but then on CT, he actually has a few tumors, one 3-centimeter tumor in segment 4, a 2.5-centimeter tumor in segment 6, and a 1.5 centimeter tumor in segment 3. And these are all consistent with HCC. There's no evidence of microvascular invasion or extrahepatic disease. So what's the next step in management? You can do an extended right. Do you want to refer them to an oncologist to begin neoadjuvant chemotherapy? Do you refer them to a radiation oncologist to consider stereotactic body radiation therapy? Or do you refer them to a transplant center so that they can be considered for transplant with bridging therapy? Okay. I think most people are answering D and oops, sorry. And that is correct. So this does fit the Milan criteria. So this patient is eligible for transplant. Will probably need some bridging therapy in the meantime while he gets listed and gets a transplant. Okay, moving on to the pancreas. So the most common causes of acute pancreatitis, I'm not going to belabor the pancreatitis slides because I think you guys will probably have a lot of experience with that clinically. Just remember that the Atlanta classification is often tested, differentiating between the pseudocysts versus an acute peripancreatic fluid collection and a walled-off necrosis versus an acute necrotic collection. So basically the 4 weeks from symptom onset is the key threshold. So anything greater than 4 weeks, that's when you can start calling it a pseudocyst or walled-off necrosis. And then we should all know the treatment for this. You don't need to keep them on bowel arrest. Enteral feeds are safe for these patients. Antibiotics is not indicated for simple acute pancreatitis. And if you do suspected persistent biliary obstruction, then you can consider an ERCP, but it's not required. Necrotizing pancreatitis. So the main thing to know for necrotizing, I think, is understanding the step-up approach. So our open debridements are really out of favor now, unless absolutely necessary. You try drainage techniques, you try upsizing drains, you try minimally invasive necrosectomies, depending on your institutional capabilities. So that might be either from endoscopy or from a VARDS procedure, which is a video-assisted retroperitoneal drainage. So your open debridement techniques are really that last choice because they're so associated with a high mortality rate from these patients. And then for chronic pancreatitis is when you get all these questions of all these type of pancreatitis drainage procedures. So I've provided sort of a classification here. And I think the main thing to know for these is which ones are pancreatic head resecting. So remembering that the Fry procedure or the lateral pancreatojejunostomy has a head resection versus the Pistow procedure does not have a pancreatic head resection. So the key is knowing what has a pancreatic head disease and understanding what your procedure needs. If you have any suspicion for malignancy, though, none of these procedures except for a Whipple procedure is an oncologic procedure. So if you have a suspicion for a tumor or anything like that, you should be doing a Whipple. And then also don't forget that a distal pancreatectomy is also a viable pancreatic procedure. So if you only have a disease in the tail, you can do a distal panc. In the interest of time, again, I'm going to kind of breeze through the questions. Again, these slides will be available to you guys later. And then going on to cystic neoplasms. So these are the 4 kind of common neoplasms that you'll be asked to differentiate between. A serous cystadenoma is the most common benign, and it has a low CEA and amylase level. All the others have some malignant potential, and so therefore they have indications to resect depending on some other characteristics. MCNs and solid pseudopapillary neoplasms typically resect. Serous cystadenomas, you only resect if they're symptomatic. IPMNs, any main duct involved disease, so that includes main duct IPMNs and mixed types. They do have an indication for resection due to their malignant potential, but branch duct only, there's a whole guidelines in terms of when to resect those. They're called the Fukuoka guidelines, most recently updated in 2016. I think for the ABSITE, if you want to focus on one part of this to know, it's the high risk stigmata. These, if the branch duct IPMNs have any signs of these high risk stigmata, you definitely want to recommend resection for these, and that includes obstructing jaundice, enhancing mural nodules, and a main duct dilation greater than 10 millimeters or 1 centimeter. The Fukuoka also classifies worrisome features, so that's sort of the next tier, and that gets a little more complicated in terms of what's indicated for those. Typically, you need to do further workup with an EUS, but I've listed those worrisome features here as well. Pancreatic neuroendocrine tumors. So I'm gonna, just in the interest of time, I'm gonna go through I'm gonna kind of skim this because I think we have a nice endocrine and GI hormone talk after this. And then after that, you can kind of come back to this chart to kind of relate it back to pancreatic neuroendocrine tumors. I kind of laid out the key features of functional PNETs here. Please remember though that the actual most common PNET is actually a non-functional PNET, so that's very important to remember. But if we're talking about functional PNETs, then here's the sort of spread of characteristics. I've included some illustrations of relevant anatomical things. I don't know if anyone's seen this on the right here, this kind of drawing of helping you remember where the PNETs are, but this has helped me a lot in the past. Each color is a letter, so this black G is a gastronoma, somatostatinoma for the red S, the green I is insulinomas, the blue V is VIPomas, and then it's not that it's actually found in the spleen, but it's something to remind you that it's in the tail for glucagonomas. Okay. And then for biliary disease, I'm not going to belabor benign biliary disease. I think we all know how to manage gallstones, or hopefully we all know how to manage gallstones. I think the keys in addition to that is gallbladder polyps. You find them fairly frequently incidentally. If they're small, less than 6 millimeters, you don't usually really need to survey them, but at least frequently, maybe every couple of years. But when you get over 6 millimeters, then imaging is indicated. And if you get over 1 centimeter or 10 millimeters, a cholecystectomy is indicated as well. And then if they're large enough in the 2 centimeter range, then you treat them like they are presumably gallbladder cancer. Gallbladder cancer, just to remind you, there's risk factors for chronic inflammation, polyps of greater than 1 centimeter, and PSC, primary sclerosing cholangitis, is also a big risk factor for gallbladder cancer. And I think the big scenario that we often get is you do a cholecystectomy, the pathology comes back with the foci of malignancy, of foci of gallbladder cancer. What do you do? So it depends on the staging. So T1A tumors that only invade up to the lamina propria, a cholecystectomy is sufficient, and that's all you need to do. But anything greater than that, so anything that involves a muscularis or beyond, or T1B or greater, it needs additional resection. So you need to actually do the central hepatectomy or a 4B and 5 resection with lymphadenectomy. Colodocal cysts also come up a lot on ABSITE, so knowing the types of colodocal cysts here, and all of them have an indication for resection if feasible, because of their malignant potential. And then these are just my last few slides, just going very briefly over transplant. I know we have seen this since step 1, but they still kind of test you on this of the types of rejection, knowing the different phases of or the different categories of rejection in terms of hyperacute, acute, chronic, and graft versus host. I put on this slide sort of the key buzzwords you might see. So hyperacute comes from ABO incompatibility, and you'll get thrombosis. Acute, you'll get on the pathology from a biopsy, for example, you'll see leukocyte infiltration. And while chronic, you'll see that intimal thickening and fibrosis. I think the other important things to know is that both acute and chronic are T-cell mediated. Graft versus host is also T-cell mediated, but from the donor T cells. And then knowing the type of hypersensitivity here, which I've listed. And then remembering how to manage these patients post-transplant is important as well. So I've listed some of the key immunosuppression classifications and the key immunosuppression drugs. And then I feel like they ask us a lot in terms of post-transplant infections and malignancies. CMV and pneumocystis are very common. BK virus is also common. They like to try to trick you with this, where they ask what's the most common malignancy from after transplant, and everyone kind of jumps to post-transplant lymphoproliferative disorder because it's that transplant-associated malignancy. But the actual most common cancer malignancy in transplant patients is skin cancer, just like in the general population. If you do get PTLD, which is a type of lymphoma usually associated with EBV, the treatment is to reduce the immunosuppression for that. And I'm sorry for going over, but here's some more questions, and thank you for your time and consideration.
Perfect. Thank you, Rachel. I realize I also didn't give a proper introduction to Rachel, but now that we have a quorum of everyone here, I can say thank you to Dr. Rachel Kim, who is a resident from Indiana University that's been there for 4 years. So I really appreciate this super complete review of HPV and transplant. There's a lot of material, as you guys can gather. So I'm going to turn it over to Wilson, who's going to be putting up his slides in a quick couple of minutes. I saw a couple hands raised. Does anyone have any brief questions on HPV and transplant that we can address right now before we move over to endocrine and GI? Happy to also answer questions at the very end, if you guys want to save it for then. All right. So I'm not seeing anything pop up in the chat. So why don't we kind of go to our next speaker. So our next speaker is going to be Dr. Wilson Alubia. He is a 4th-year resident at Stanford. He's also the inaugural education chief resident there. So you guys are in for a treat with an expert kind of going through endocrine and GI. So I'll turn it over to you, Wilson.
Thanks, Raja. Everybody hear me okay? Excellent. All right, go straight into it. So these are the topics under endocrine when you look at the curriculum outline on SCORE. So we're going to try to go through a lot of these topics very briefly, but also very quickly. As you know, there's a lot of information, and so this is not going to be comprehensive. It's meant to be a review, so some of this stuff will be geared towards the junior residents and others towards the senior residents. So just pick and choose what part of these will be helpful. Questions that I present here are from CSAP, and so I'm just saying that for any copyright issues. And a lot of these slides I actually adopted from Dr. Dahl Cassidy's talk at this same meeting, at this same sort of venue about 2 years ago. So let's go straight into it. So starting with adrenal, so adrenal anatomy. So as we know, these are paired endocrine glands that are in the retroperitoneum. If you remember from medical school, you have an outer cortex that's divided into 3 different portions. So the glomerulosa, fasciculata, and reticularis. And then the inner portion is obviously the medulla that is involved in catecholamine synthesis. For arterial supply, this is actually pretty frequently tested. The superior portion of the adrenal gland gets its blood supply from the inferior phrenic artery. And then the middle portion of the adrenal gland gets its blood supply directly from the aorta. And the inferior portion gets its supply from the renal artery. It's super important to remember. Venous drainage depends on what side of the adrenal you're talking about. So the right adrenal, because of its proximity to the IVC, drains directly into the IVC, whereas the left adrenal gland drains into the left renal vein. So adrenal tumors, we're obviously seeing more of them because of the widespread use of cross-sectional imaging, so a lot of incidentalomas. But it's always important to remember that every time you're faced with an adrenal tumor, there are three main questions you need to ask yourself. One, is this tumor functional or non-functional? Is it benign or malignant? And if it is malignant, is it primary or secondary? So those are the three things that you always want to ask yourself when you're faced with any adrenal tumor question. So as we see here, just like I reminded you before, so if you're trying to determine whether the mass is functional, this really depends on where it is in the adrenal gland. So remember we talked about the GFR. So the glomerulosa is always on the outside, the fasciculata in the middle, and the reticularis is sort of much closer to the medulla. So these adrenal cortical tumors, that just means you have a tumor in the cortex, so in one of these three regions. And if it's in the glomerulosa, this is the part that is responsible or involved in salt metabolism. So this is where you have your aldosterone synthesis. So a tumor in this part of the adrenal gland leads to hypoaldosteronism. And obviously one in the fasciculata will lead to hypercortisolism because that's where cortisol is synthesized. And then one in the reticularis, because that's where androgens are synthesized, will lead to hyperandrogenism. And that is actually managed more by medical endocrinologists. So we're not going to talk much about that here. And then in the medulla, that's where, like we said earlier, we get our catecholamine synthesis and conversion of norepinephrine to epinephrine. So that's where patients can have homocytoma. So going through these from the top, so from the glomerulosa, we have, like I said, we have the aldosterone. And this aldosterone actually works by increasing sodium reabsorption and potassium secretion in the distal tubules of the kidneys, and also leads to an increased hydrogen excretion in the collecting duct. So, and this actually happens through the renin-angiotensin pathway, if you remember from medical school. So when you have a patient that has hypoaldosteronism, these are the lab abnormalities that you would find. Because they're reabsorbing more sodium and excreting more potassium, they're more likely to be hypernatremic and hypokalemic, and also can have metabolic alkalosis. So a typical presentation, these patients would have poorly controlled hypertension because of the increased sodium load that can lead to chronic hypertension, and can also have, because of hypokalemia, symptoms related to hypokalemia, so cramps, weakness, and if it's severe enough, you can have some EKG abnormalities. So the differential, when you have a patient with hypoaldosteronism, whether it's primary versus secondary, obviously primary means you have a tumor or mass that's in the adrenal gland itself, whereas secondary, if you remember from the renin-angiotensin pathway, has stuff to do with both the kidneys and the lungs. So when you have patients with CHF, cirrhosis, and renal artery stenosis, those can activate the renin-angiotensin pathway that can then lead to increased aldosterone production, which can cause a hypoaldosteronism. So it's important to remember when you have a patient with hypoaldosteronism, or you have a question that has one, to always think, is this primary or secondary? Because they might try to trick you by putting one of these secondary causes there, just to make sure you know that that can actually cause Cushing's syndrome. So for the workup, for the ABSITE, these are three variables that we need to remember. So the plasma aldosterone concentration, the PAC, the plasma renin activity, and then the aldosterone to renin ratio. The two numbers that you need to remember is the one number that you really need to remember is aldosterone to renin ratio, which should be greater than 30. That's usually the answer that you're looking for. And once you confirm the diagnosis, the way to lateralize which of the glands has this tumor is usually with a CT. In the past, people have done selective immunoscapularization and looked at sort of the aldosterone cortisol ratio, but that is not used very much these days. The treatment obviously depends on how much of the gland is involved. So if you just have one gland and you have an aldosteronoma, usually just do laparoscopic apinealectomy. But if you have somebody that has tumor in both glands, then you have to start worrying about them losing both glands, which is pretty morbid. So those are patients that end up more on medical therapy with aldactone. Next in zona fasciculata is cortisol, so Cushing's syndrome. Obviously, we all know function of cortisol raises blood glucose both directly and indirectly. And it does this mostly by increasing insulin resistance. And so the cells see more glucose and are able to use more glucose. We all know about anti-inflammatory and immunosuppressive effects of steroids. And so the presentation here, as we all remember, they have central obesity, as you can see in this picture, is pretty significant stretch marks of striae. These patients can have morbid, pretty significant moon phases and signs and symptoms of diabetes, usually related to this increase in insulin resistance. So the differential diagnosis here, and this is another common question on the ABSITE, the most common cause of hypercortisolism is actually exogenous steroid use. So always make sure that patient is not taking steroids. And if they are, make sure they're not taking too much steroids, because that's what will cause them to have Cushing's syndrome. And the most common endogenous cause is actually tumor in the pituitary gland. You can also have ectopic ACTH secreting tumors. So these are tumors that are found in the sort of the bronchial carcinoid tumors, thymomas, small cell cancer. Another very common question on the ABSITE, where they give you a patient who has symptoms of Cushing's syndrome, but on a CT scan, we're found to have some sort of lung mass. That is your clue to know that this may be an ectopic ACTH producing tumor, and so it needs to be worked out further. And then you can obviously have intrinsic or primary adrenal tumors, so adrenal cortical cancers, adenomas that can produce cortisol as well. All right, so for the workup of hypercortisolism, so two ways. The most sensitive and most specific is the 24-hour urinary free cortisol. And that's because you're able to collect the cortisol levels throughout the day and able to actually follow the trend over the day. You can also do the low-dose dexamethasone suppression test. And this is always confusing, but the way I remember it is that you're trying to use the diurnal distribution of cortisol levels throughout the day to help you determine where you are. So usually you give the patient a low-dose steroid at about 11 p.m. when the steroid levels in the body at a physiologic state is very low. So when you stress dose them, you're hoping that you're going to prevent the body from secreting or making more cortisol. And so if you check a cortisol level at 8 a.m. when it's supposed to be the highest physiologically in a normal person, because you stress dose them, you hope that they do not have this response. And so if at 8 a.m. you see that a patient has a pretty significant amount of cortisol, that tells you that they do have some tumor somewhere that's producing all that cortisol. So there's a few ways to try to figure that out. So if you do a stress dose or low dose dexamethasone suppression test, and you have low plasma ACTH levels in the morning, then that means that they did adequately suppress. And so that tells you that this is probably a tumor in the adrenal gland that responded to that steroid stress test. If you do have pretty high ACTH levels, even despite the suppression test at 11 p.m., then that tells you that that steroid or that cortisol is coming from someplace else outside of the adrenal gland. So that's when you start looking through for other causes. So the ectopic ACTH producing tumors in the lungs or something in the pituitary. So that's, if you want to actually work that up further, then you can do a high dose dexamethasone suppression test. And that even suppresses the cortisol levels even further and helps suppress the pituitary axis from producing more cortisol. So that's your way of trying to figure out if there is a tumor in the pituitary gland or elsewhere in the lungs or bronchial carcinoid or a thymoma or something else. So those are two things to remember. Low dose suppression test will tell you if it's in the adrenal gland, and the high dose suppression test will tell you if it's somewhere outside of the adrenal. And then for these tumors, CT or MRIs are helpful for localizing these tumors. So this is just a very quick chart that, like I just talked about, it's helpful. Once you get these slides, you can go through it and it helps break it down a little further. So for pheochromocytomas, we're talking about the medulla now. So as we remember from medical school, tyrosine is a precursor molecule for the production of norepinephrine and epinephrine. However, in order for you to make epinephrine, you need PNNT. That's really only found in the adrenal gland and the organ of Zuckerkandl. And once you produce your epinephrine, it has, when it gets broken down, you require this COMT enzyme to break it down into metanephrine. And that's helpful because that's how we're able to work up these patients. So as we all know, very classic symptoms of pheochromocytoma, significant hypertension, headaches, tachycardia, palpitations, significant sweating. Those are all clues for you to remember that this may be a pheochromocytoma. For plasma metanephrines, these are highly sensitive, but not as specific. The urine, again, urine 24-hour fractionated metanephrines is the most specific and most sensitive when it comes to working up patients for pheochromocytoma. For imaging, to help determine whether a patient has pheochromocytoma, you can get a CT scan with an adrenal protocol. In these scans, you expect to see some retention of contrast on the CT with no washout. This image is not very clear, but it's supposed to show you some retention of contrast in this adrenal tumor. You can get an MRI, which is very helpful because on the 2-2 phase, you see some hyperintensity because they hold on to the contrast. And then if neither the CT nor the MRI is able to tell you or localize the tumor, this the MIBG scan is your pretty much your last ditch effort because the MIBG tracer acts as a norepinephrine, and so the adrenergic tissues actually take up the tracer, and so they light up. And this is what it looks like on the MIBG scan. So these are the three options when it comes to localization of pheochromocytomas. So we all remember these rules of 10s from medical school. I just wanted to remind everybody, some of these numbers have changed. So remember, 10% of these are malignant. Now we know that there's actually a higher number of those patients have malignancy. And we used to think that 10% of them had a familial component, but that's actually more like 25% now, because we know now that pheochromocytomas are a huge portion of MEN2A and 2B disease. So for treatment, we know you should remember that this is something that actually you start treating in a preoperative setting. So these patients require alpha adrenergic blockade because remember, epinephrine would have significant adrenergic effects. And so alpha agonist effects. And so you want to block that effect. Typically, we use phenoxybenzamine because you get a little bit of beta blockade component as opposed to if you use doxazosin or prazosin, which only have alpha adrenergic tone effects. So usually you'll see more people using phenoxybenzamine than doxazosin and prazosin. And this is, I've actually seen this question once. I don't know if it's on TrueLand or on ABSITE, but pheochromocytoma patients can have some pretty significant dehydration because of the vasoconstriction that they can experience. So some patients require ongoing volume resuscitation with isotonic IV fluids. So that's something to look out for. And intraoperatively, you need to talk directly with the anesthesia colleagues because it requires a lot of collaboration. And post-op, these patients can have significant severe hypoglycemia. So remember to have glucose sources available in the post-operative setting. So once you get these slides, this is a good slide to look at for adrenal incidentalomas. Will help you sort of, the biggest thing here is remembering the size differences and the vascularity differences. So once you get the slides, you can take a look at that. Adrenal cortical cancer, about 40% of patients would present with metastatic disease and so are not surgical candidates, so pretty morbid diagnosis. Here, these tumors tend to have irregular borders and can have some necrosis or hemorrhage, like you can see in this tumor here. And the treatment here is to avoid biopsy in these tumors because they can see the tract that you're biopsying through. And if you have to treat it surgically, you're actually looking at an open adrenalectomy. And if a patient has metastatic disease, this is actually a question on the ABSITE. Mitotane is the answer for metastatic disease that you cannot treat surgically. For MEN syndromes, remember MEN1 is the 3 Ps, so pituitary, parathyroid, and pancreas. MEN2A and 2B is when you start seeing pheochromocytomas and medullary thyroid cancer. All right, so I'm going to do one question here, and then we'll move on for adrenal. 72-year-old gentleman who has a 2 centimeter homogeneous right adrenal mass. He was treated and sent home and then referred to you as an outpatient. The question just says, what do you do next? This question really just hints at making sure that you rule out any functionality of this tumor before you take him to the operative room. We'll move on here to thyroid. So thyroid anatomy, so bilobed organ in the neck. The arterial supply is usually from the external carotid artery. And then this is of the superior part of the gland. The inferior part of the gland gets its blood supply from the thyroid cervical trunk, which comes up the subclavian. So that is a question on the ABSITE, the inferior thyroid artery and where it comes from. And then sometimes they'll show you on ultrasound. So this is how you read it. So always start with the trachea. Then this is the isthmus right above the trachea, the right thyroid lobe, and then the artery below it, and then left thyroid lobe and artery below it. Then these are the strap muscles right on top. You can correlate that with the CT here as well. So what do you do with thyroid nodules? Always start with the TSH level and an ultrasound. When you look at the TSH, if they're hyperthyroid, so the TSH levels are low, then you always want to get imaging to determine whether they have a hot or cold gland. And if it's a hot gland, then you have to determine what's the distribution. So if it's just diffuse, then you're talking about Graves. If it's solitary, you're talking about a solitary toxic nodule. And if it's heterogeneous, then you're talking about a toxic multinodular goiter. And if it's a cold nodule, so that tells you it's not functional, or they're hypothyroid, then you have to get an FNA biopsy. This is the TIRADS. It's a very common question, especially these two, so TIRADS 2 and 3. The answer is always molecular testing, and this is usually the one that they would always test, the follicular neoplasm or suspicious of follicular neoplasm. The answer there is always molecular testing, so you can know exactly what tumor you're doing. I'll skip this slide because we all already know that. On this slide, I was trying to highlight the importance of total thyroidectomies versus lobectomies when it's important to do those. The biggest point here is that the benefits of a completion thyroidectomy is that you remove all the tumor that's available, and that allows you to use radioiodine therapy in the future because there's no thyroid tissue left to take out that radioiodine. So you can tell for sure if there's a recurrent or metastatic disease, and you can follow these patients with the thyroglobulin because there's no thyroid tissue left to produce thyroglobulin. And so as soon as they have some evidence of thyroglobulin, you know they have recurrence. Adjuvant therapies, you can read this once you get the slides. Radioactive iodine, this just goes through what the recommendations are, not a very important slide. Midline thyroid cancer, remember, comes from peripheral C cells. The biggest point here is to remember they're associated with MEN2 syndrome, so 2A and 2B. That's the biggest thing to remember on this slide. And when you're faced with a patient with a non-metastatic midline thyroid cancer, the answer is always taking out the entire thyroid and doing bilateral central neck sections because these tend to be widely metastatic. And midline thyroid cancers would not respond to radioactive iodine because the cells are not able to concentrate iodine. And another outside question, which is how do you follow these patients for recurrence? The answer is by following the calcitonin. Benign thyroid disease, very common. I'll leave these here for you to review once you get the slides, but the biggest one here is the dequavins. And always remember that's the one that's painful and you can treat with NSAIDs. I'll skip these thyroid questions in the interest of time, but this one just, again, goes to talk about sort of if you have a patient who has a suspicion for follicular neoplasm, the answer is follicular testing. And there's another question that you can review once you get the slides. Parathyroid, very quickly, so small parent organs. Another outside question because it throws a lot of people off. The blood supply for all the 4 glands is from the inferior thyroid artery and it comes in from medial. The superior glands, again, for those who are taking the junior ABSITE, the junior version of the ABSITE, these are very common questions. The superior glands come from the 4th branchial pouch, and they sit more in the posterior lateral aspect of the gland, whereas the inferior glands come from the 3rd branchial pouch and are more anterior. And when you're looking for ectopic glands, these ones tend to be more anterior and can be found in the carotid sheath, whereas the ones that are superior tend to be more posterior and are found in the tracheoesophageal groove or in the esophageal space. As we all know, so PTH, the way I remember this is a phosphate trashing hormone. So your phosphate numbers get low and your calcium levels get high because you break down, your osteoclast function is high in the bone. That helps you secrete a lot of calcium. Important to remember the difference. So calcitonin, it comes from C cells, and then the PTH comes from chief cells in the thyroid and the parathyroid gland. And this just tells you it works by the cyclic AMP pathway. And the net effect is elevated calcium, and again, phosphate trashing hormone, so low phosphates and elevated chloride, because that's how it's exchanged in the kidneys. And then talking about primary hyperparathyroidism. So this is when you have one or more parathyroid glands that function abnormally to secrete inappropriate levels of PTH. So you have something that is intrinsic to the parathyroid. Secondary hyperparathyroidism, you have something outside of a parathyroid that's causing you to have symptoms of hyperparathyroidism. And so you treat the underlying problem. So if it's renal failure, you treat the kidney disease. If it's low vitamin D, you give them vitamin D. And then tertiary hyperparathyroidism is what you see in post-renal transplant patients. So we've talked about this a lot. One thing to remember here, when you're faced with a patient with primary hyperparathyroidism, always remember to rule out familial hypocalcemic hypocalciuria, because that's a genetic version that can present as a hyperparathyroidism. And that's what the question is going to be, looking to rule out familial hypocalcemic hypocalciuria. And then all symptomatic patients require surgery, and these are indications if they're not symptomatic, usually age-related, and if they have a T-score less than 2.5. So how do you localize parathyroids? Usually using a sestamibi scan, you see the parathyroids here, and then you see this little left-sided gland that's retaining the tracer, so that tells you that's the tumor that you're going to go after. And that, in association with the 4D CT scan, helps you increase your sensitivity and specificity. And then here, very briefly, I wanted to go over the importance of remembering the function of the recurrent laryngeal nerves. So if a patient has any of these, so a very bulky tumor or prior neck dissection, you want to obtain a cross-sectional imaging and, more importantly, a preoperative laryngoscopy. I've seen this on the outside. You need a preoperative laryngoscopy if they have a previous neck dissection, a bulky tumor, or a lateral lymph node involvement. And that's just to help you know what their baseline vocal cord function is prior to going to the OR. The recurrent laryngeal nerve injuries, if you have only one side involved, these patients just have dysphonia. And so just Botox injection would help medialize that cord and help their voice get better. But if you have bilateral injury, then these patients are at risk for vocal cord paresis, and so would need a tracheostomy. And then finally, if you're in the OR and you find out that you have possible injury to the nerve, then this is an opportunity for you to stop and then do a staged operation so you don't risk injury to the other nerve. This is another parathyroid question that I'll leave for you to look at later. And then very quickly, talking about GI hormones, the big two that I've seen on ABSITE frequently is the secretin and cholecystokinin. So secretin, remember, it's easy, produced by the S cells in the duodenum, and then stimulates a bicarb release. And then cholecystokinin is secreted also in the duodenum by I cells, and that stimulates gallbladder contraction and sphincter of OD relaxation. These are the big two. However, there's others. So like Rachel talked about earlier, the gastrinomas and the VIPomas are ones that are tested as well. So this is a slide that actually summarizes that and makes it a lot easier. I look at this slide usually just before the ABSITE to remind myself of all the GI. I believe that's it. Sorry, I had to rush through this because there's not a lot of time. There's a lot of information to go through. So happy to take any questions.
Thank you so much, Wilson. That was awesome. That is a very good comprehensive review of endocrine, which again is another very high yield, very broad topic, very nicely summarized. And echoing what our speakers have already said, all the slides will be available to you on the SSAT website. At the end, you'll get an email if you were one of the folks that registered. So that way you'll know when you can access them and review these if you'd like at a later point, in addition to the audio recording as a podcast and as the video. So to take us home, we're going to now turn it over to Dr. Connie Shao, who is a third-year resident at UAB and also an emeritus moderator for this panel and an executive member as well with the Society of Academic Asian Surgeons. So I will let you take it away.
Awesome. Thanks, Raja. I'll go fast. Colorectal. So I'm going to do some basics, anatomy and physiology, go over the colon diseases, benign, IBD, malignant, and anorectal. So basically for the anatomy, most importantly, you just want to know the arterial and venous supply. So the first 2/3 of the transverse colon, and obviously the midgut duodenal ampulla to the first 2/3 of the transverse colon are SMA. Hindgut is going to be distal transverse to descending colon, and proximal rectum, which is going to be IMA. And this applies like the final portion of the colon and proximal rectum. And then you have the internal iliac artery that supplies the distal rectum. And then importantly, you also have to consider the venous drainage of the different components as well, which I'll talk about for the next slide for the rectum. Importantly, you have to consider the different layers for colon cancer staging. So the colon has 4 major layers. You have the mucosa, which is columnar epithelium, and the submucosa, which includes the muscularis mucosa. I would say that's the most important. And the muscularis propria, the inner circular and outer longitudinal smooth muscle, and then the serosa. And then the longitudinal muscular layer has the 3 distinct bands, the tenia coli, that converge to the top of the rectum. And then these longitudinal bands, they produce seculations and haustra, which give the colon its typical radiographic appearance that you see on KUB. The typical diameter is about 7.5 centimeters. Cecum is the most capacious area that gets up to 12 centimeters when you start getting worried about necrosis. The appendix is from the base of the cecum, and it's usually within 2 to 3 centimeters of the ileocecal valve. And it's at the convergence of the 3 tenia coli, and it gets its blood supply from the mesoappendix that traverses the mesentery. And then basically these are like the watershed areas where you get concerned about ischemic colitis with any form of hypotension. And then looking at the anorectal anatomy, most importantly, you have the dentate line that's going to sort of define a lot of anatomic boundaries. So the upper third of the rectum is covered anteriorly and laterally by the peritoneum. The middle third is covered by peritoneum only anteriorly, and the remaining distal rectum is entirely retroperitoneal. And then very importantly, the posterior rectum and the surrounding mesorectum abut the presacral fascia, and this is enveloped by a distinct mesothelial layer known as the fascia propria. The rectal drainage system, you have the upper and middle thirds of the rectum that drain primarily into the superior rectal vein and empty into the liver via the IMV and portal vein. But then the lower third of the rectum drains into the middle rectal vein. And then this blood in the middle rectal vein just skips the liver completely and drains directly into the IVC. Now, the dentate line is important because it defines the anus. So traditionally, this is defined like the sort of the anal canal and the anal margin, although clinically the surgical anorectal junction begins at the level of the pelvic floor muscle. So the mucosa at the dentate line forms longitudinal folds, and those are the columns of Morgagni. And you can often have obviously infections there that result in anorectal abscesses and fistulas. And then let's see, and the dentate line is super important too, because the nerves, lymphatics, blood supply, and mucosa are very, very different above and below that line. And so here's a little bit more about it. The anal canal sort of starts at the puborectalis sling, which is the anorectal ring, and then it ends at the anal verge. And then the anal margin is important for squamous cell cancer and extends 5 centimeters radially from the squamous mucocutaneous junction. These anatomic boundaries are just important for sort of defining like what is the anus and what is the rectum, so that you can figure out how to deal with different kinds of cancers. Physiology, here's just some buzzwords. Colon is for water and sodium. The energy is from short chain fatty acids. This is like not super PC, but I just think butyrate, like booty rate for butt and colon, and then glutamine for enterocytes. And then here is basically sigmoid and cecal volvulus. Sigmoid volvulus you typically think about for older patients. And there's typically good endoscopic management for this. And you can think, obviously, it makes sense because it's like distal, it's right where you would get in with a scope, versus for cecal volvulus, you have to do a resection. And you obviously just see sort of like a coffee bean pointing to wherever this volvulus is going to be. And then C. diff colitis, it used to be that you managed it with Bank, but now for the axamycin, if you go on UpToDate, this is like the standard of care. And then obviously an alternative can be Bank, and then you can try that a couple times. And if it doesn't work, you can consider microbiota transplantation, fulminant C. diff, you want to start considering Bank enemas as well. And then obviously surgery if you have severe colitis. Perforation is associated with really high mortality, so you have to be diligent about operating early if there's somebody that you're concerned about perforation. And then you do a subtotal colectomy with ileostomy. Diverticulitis is just basically microperforations or a full-on perforation of somebody with diverticulosis, which is typically weaknesses in the colonic wall, just from where like the blood vessels protrude through like the mucosa. And so you can have mild uncomplicated disease that you can manage with IV antibiotics if they're not tolerating PO. If they are able to tolerate PO and don't have horrible abdominal pain, sometimes this can get managed outpatient. But typically when you're seeing somebody in the ER and the questions they'll ask you about, they're like vomiting, have bad abdominal pain. You just want to manage them with IV Zosyn until they do have improved exam. And then here's sort of the different Hinchey classification. That's basically you have pericolonic abscess that's smaller than 4 centimeters, antibiotics. If it's greater than 4 centimeters, include drainage, so you need source control. If you have purulent peritonitis, you start thinking about surgery, and then feculent peritonitis, surgery as well. And then for these people, they all need to get a colonoscopy afterwards because you need to figure out why this happened. Sometimes it can just be from diverticulitis, but typically you need to make sure that it's not because of cancer or some kind of colonic ischemia or IBD. And so obviously it used to be that you would always talk about elective colectomy for anybody who had any kind of diverticulitis, but now it's sort of a complicated decision-making process about, whether or not this is, the first bout is always the worst. And so you can counsel them on that. And then you talk about, the pros and cons of having surgery, especially if it's an older patient, if you might want to forego having surgery, or if it's somebody who has like a very functional, high demanding lifestyle that you would probably want to do surgery on so that they can avoid being hospitalized frequently. Ogilvy's is typically for our patients that are coming in from nursing homes that have a lot of opiates on board, or there's somebody who had some kind of orthopedic surgery, something like that. They're like some kind of chronically ill patient typically. You always want to be on the lookout for perforation. For these people, when they come into the hospital, you ideally can just support them through it. And then if you can't, you can consider neostigmine. It can cause significant bradycardia. So you always want to make sure they're in the ICU. It's an anti-acetylcholinesterase. So just have to be very careful when you give it. It needs to be in a very monitored setting. And then if they're still not improving, you can consider endoscopic decompression. If you're getting worried about ischemia or perforation, you want to start thinking about surgery. And then for lower GI bleeds, you always want to rule out an upper GI bleed, and you always want to be thinking about your resuscitation principle. So 2 large bore IVs, make sure there's blood available, and admit to the ICU. Sometimes they can stop bleeding. They're usually caused by diverticulosis, but there's a lot of other causes as well. And here's the different types of scans that you can do. If you want to catch the slowest kind of bleed, you can consider nuclear scintigraphy, and then the fastest bleed you can catch on colonoscopy. So the con of colonoscopy is that it has to be a brisk bleed in order for you to see it, and oftentimes it's not prepped. You can't see because of the blood, but the pros are that you can actually do an intervention that's therapeutic. So obviously with all these GI bleeds, you want to consider IR and colonoscopy, but then, you have to create some kind of cutoff, and traditionally it's been 6 units of red blood cells in 24 hours, or if somebody's becoming unstable, then you would consider doing a segmental colectomy because people typically have pretty poor outcomes with a total abdominal colectomy. So here's a question about somebody that you're concerned about Ogilvy's essentially. So the answer for this one is you can't just treat right away. You have to consider doing a gastrograph and enema first, because you want to rule out that somebody has a distal blockage, because if you just give them neostigmine and they try to move everything through and there's a distal blockage, you're like in a bad place. So this is somebody that if they had a gastrograph and enema and you just found a mass, you might want to consider colostomy as well. So now on to IBD, ulcerative colitis. You remember the buzzwords from medical school. You want to consider medical management first. And then there's obviously increased risk of malignancy because they're in a basically chronically inflamed state. So surveillance for them is different than it is for the usual population. You want to start after 8 years of disease, and then every 1 to 2 years with biopsies, which again is not the norm for just your regular population. And then if there is some concern for high-grade dysplasia or malignancy, you want to do a total proctocolectomy. An elective surgery you want to consider for people who are basically having failure to thrive or have medically refractory disease course, or if there's some concern for dysplasia or malignancy. There's a lot of different options, but basically you want to take out the entire colon and rectum. You can consider doing an IPAA, but there's always some concern of pouchitis. You can treat pouchitis with Cipro flagyl, or you can do enemas if it's refractory. And if you still are having issues with IPAA pouchitis, then maybe you want to consider the fact that it could be Crohn's as well. The issue with an endoleostomy, the good part is that you don't have to talk as much about pouchitis, but then you are concerned about a lifelong ostomy. And then the other options, you can do it in an emergent setting, an endoleostomy. But then if you do have an ileorectal anastomosis, like in an elective setting, you need to be worried about malignancy recurring at the rectum. So you have to screen them annually for malignancy. For Crohn's disease, here's some, creeping fat granulomas, strictures. These are the buzzwords that you have. Treatment medically is pretty similar. Surgically, the treatments are never, it's never going to cure them. It's only for symptoms. So most commonly it's for strictures. You can also have perforation, obstruction, malignancy, and fistula, but the surgical treatment is never curative. And so these are the different types of stricturoplasties that you can consider for different lengths. So this is a Heineke-Michelitz. This is urology uses this a lot for ureteral, opening basically, if there's a ureteral stricture, they do the same thing. So this is very common. Stricturoplasty. This is an option if you have a FINI, basically where you just put a loop together and then create a common channel. And then here you sort of make them side to side, and that's Michelossi. It's just for a longer segment. For Crohn's disease, if you have appendicitis and you have TI inflammation, you need to suspect Crohn's. So if the cecum is uninvolved, you want to get you can take the appendix out to prevent future diagnostic confusion. But if it is inflamed, you want to leave it and back away. There's a lot of literature that's shown that if you do an appendectomy in the setting of Crohn's, basically, if you're concerned for Crohn's and you do an appendectomy, it really increases your risk of Crohn's in the future. So either way, you should treat medically for a Crohn's flare, but you don't want to make Crohn's worse by doing an appendectomy in the setting of suspected Crohn's. And now on to malignant problems. So these are a bunch of quality metrics that you should try to remember, not only for this, but also for FES. Here's screening guidelines. The age that you would start now is 45. And then there's all the different guidelines for different types of familial diseases as well, like FAP and Lynch. And then these are surveillance guidelines depending on what you had at the time of your colonoscopy. And let's see. Oh yeah. So basically this person had a malignant sessile polyp at the splenic flexure, and you should get a partial colectomy basically if it was not a complete en bloc resection. So if they had any positive radial margin. So submucosal depth of invasion it sounds like it would be something that you would be concerned about, but it actually hasn't been shown to be related to any kind of lymphatic involvement. So it's really that you want to get an en bloc resection of the actual tissue itself. And so you can't have any radial margins that are positive. This is important to consider as well. Ideally, we try to be as minimally invasive as possible. Endoscopic resection of cancers for both colon and rectal cancer is pretty similar. So basically, you just want to make sure that it's well differentiated and that you got everything. Otherwise, they have to get a formal oncologic resection. And then for colon cancer, the way that I try to remember the different stages is that stage 1 is just T1 and 2. Stage 2 is T3 and 4. So basically, once it gets past the muscularis propria, you're in stage 2. Any nodal involvement, you're now in stage 3, and stage 4, obviously metastatic. But you start talking about adjuvant chemotherapy for stage 2 and 3. And then for FAP, this is basically starting at age 20. You are at high risk of high-grade dysplasia and cancers. You want to start surveillance. And then Lynch syndrome, there's like the prior Amsterdam criteria that's kind of outdated. And so now you have the Amsterdam 2 criteria that basically helps you screen families that you think are at high risk of Lynch syndrome. And then there's a bunch of associated cancers. And then here's the principles of colon cancer resection, that you basically want 5 to 7 centimeters of the proximal and distal margin. You want sufficient lymph nodes because that's actually how you stage the end part. And then there's no radiation, unlike rectal. And then for the appendix, carcinoid tumor is the most common tumor of the appendix. If it's small, you can just do an appy. If there's increased mitotic rate, or if it's bigger, there's some concern for it, you want to do a right hemicolectomy, and you can also treat symptomatic liver disease as well. So for anal fissures, if it's not posterior lateral, you want to consider other etiologies. After you consider medical management, you want to consider a lateral internal sphincterotomy. I wouldn't worry as much about an anal-cutaneous flap. And then these are the different locations that you can have abscesses, of which many of them turn into fistulas later on down the road. About a third of them will turn into fistulas. And then if they're superficial, you want to consider doing a fistulotomy, as long as it doesn't involve 24% or more of the sphincter. Otherwise, you can consider doing a lift, like a ligation of intersphincteric fistula tract or an anorectal advancement flap. But don't do a fistula plug or fibrin glue. And then for hemorrhoids, you want to make sure for internal ones, they don't hurt. You have these 3 classic bundles. It's above the dentate line. External ones, if they're thrombosed, you can excise them within the first 3 days, within the first 3 days. Otherwise, watch them and they'll get better on their own. And then obviously you want to always do medical management with fiber. You can do topical calcium channel blockers and nitroglycerin. But then otherwise, and sits-bass, but then otherwise you'd have to consider doing banding versus surgery for internal hemorrhoids and possibly excising for external hemorrhoids. Not to be confused with rectal prolapse, which is full thickness intussusception. A lot of times it's like developmentally delayed, or psych patients that have this. Low-risk people, you would just like do a resection. High-risk people, you do an Altemeyer where you just through the anus basically take out their sigmoid. And then here's somebody that basically you can see here that there is an anal fissure. And so this person's already had medical management, so you want to consider doing surgery. And then for rectal cancer, this is how you work it up. Importantly, it's a rectal MRI. In the past, people talked about an EUS, and that's not what we do anymore. For these patients, stage 2 or above. So staging system is the same. Stage 2 or above, you want to do neoadjuvant radiation. Even if you have a complete clinical response with neoadjuvant chemoradiation, you still need resection. And then if same thing with colon cancer, if you have T1 lesions without high risk features and all those things, you can do just an endoscopic resection with the just with a scope, you can get the whole polyp. And then the surgery is different. So the margin, you would try to get as much as possible, just like with colon cancer, about 5 centimeters. If it's in the upper third and the mid to lower third, you try to get 2. If you can't, maybe 1. But if you can't achieve an adequate resection, you have to do an APR. And then for stage 3+, you want to consider adjuvant therapy. And then squamous cell cancer, this is where it's important to consider the margins of the anal canal versus the anal margin. And so for this one, you would do a NIGRO protocol. And if it's refractory to that, you want to do an APR. These are different words that mean squamous cell cancer, but they just used fancy words during the test. And this is different from the anal margin, which will be 5 centimeters radially from the squamous mucocutaneous junction. And that one, you treat like a skin cancer, do wide local. Melanoma, you do an APR. Small rectal carcinoma, you do a local excision, versus greater than 2 centimeters, you'd need to do an oncologic resection. And that's it. Thanks, everybody.
All right, that was an awesome whirlwind review of colorectal. Probably, I think, the highest yield of what we've talked about for today, because there's a lot of possible topics there. Thank you, Connie. That was a great job. We have just a few minutes left, so I just want to highlight again that the recording from today's talk and the slides will be available on the SSAT website, before we have the next part 2 session that's going to be happening in January. So you'll have that to access as well. Does anyone have any questions in the last 5 minutes before we can close out? You guys can feel free to just raise your hand, or you can put questions out in the chat and we can go through there. Okay, maybe we want to throw it quickly to Rachel to put up her slide if you have a second.
Yeah, let me pull up that relevant slides. It's a good question. So yeah, so the Beggar procedure is really mostly mostly a pancreatic head resection. Now it does require a dissection all the way down to the level of the portal vein. So you're making a tunnel similar to what you do for a Whipple. And because of that, you do need 2 anastomoses. So you bring up a limb and you anastomose to the pancreatic head, and you bring anastomose to the distal pancreas as well. But importantly, this is still not an oncologic resection. You're really just coring out the pancreatic head. And then also importantly is that it's not a decompressive procedure for the entirety of the pancreatic duct, and that is the main difference between the Beggar and the Fry procedure. So the Fry procedure also has a pancreatic head resection, but it also is a lateral pancreatojejunostomy. So it's almost sort of like a combination-ish between the Beggar and the Pisteau. So if you have a dilated duct all the way down to the distal duct, but you also have pancreatic head disease, then a Fry is what you probably should do, as long as you're not suspecting any malignancy. If you really just have proximal pancreatic head disease, then a Beggar might be more appropriate. There's also a burn modification of the Beggar, where you're not dissecting all the way down to the level of the portal vein, so you can just do 1 anastomosis, 1 pancreatojejunostomy. Well, the Fry is also 1 anastomosis, but you kind of, just like the Pisteau, you fillet that entire thing open. Hope that helps.
This is a great slide to really go through it. I think the burn modification, while it's an interesting sort of like a historical option that's often described in Germany, used there, it's not commonly one that I would suspect comes on the ABSITE, but certainly differentiating the Beggar versus Pisteau and Fray, just like she mentioned, is probably the key features here. And knowing when you can do something, when you know that you're dealing with benign disease, versus if there's any suspicion for, or strong suspicion for malignancy, you need an oncologic resection with a Whipple. Perfect. All right. I'm not seeing any more questions pop up, so maybe we can give you guys 2 minutes back. We'll have, again, the podcast, the video here, and the slides available for you to review. And then we'll also be posting about the part 2 session that's going to be hosted by one of our colleagues, Dr. Victoria Gershoni. So she'll take you through a couple of other subjects that we didn't discuss here. So good luck to everybody. Thanks for joining us. Good luck on the ABSITE. And thank you again to our panelists here that gave such excellent presentations. Everyone have a good night.